Hi, good evening. My name is Carla Sepulveda. I'm the Director of Breast Imaging at Baylor St. Luke's Medical Center. I want to welcome everyone this evening. We have physicians from Latin America, the Middle East, and the United States joining us. I want to say buenas tardes and ahlan wa sahlan to all of those joining us this evening. We're glad to have you here. As you may know, the Daniel Duncan Cancer Center is one of two NCI designated cancer centers in Houston, and we also are ranked by US News and World Reports as one of the top cancer centers in the United States. As part of our mission to promote medical knowledge through educational programs, the International Center at Baylor St. Luke's in Houston, Texas, in collaboration with Baylor College of Medicine, is honored to host our 6th International Virtual Roundtable to our network of physicians, medical societies, and the international medical community. Today's topic will be a debate in which our speakers will discuss neoadjuvant endocrine therapy. Should it be standard of care for all women with ER-positive breast cancer? I want to step through a little explanation of today's program. First, we will have the debate of my dear colleagues, Dr. Thompson and Dr. Ellis. There will be a presentation by Dr. Ellis on the pro side, and then there will be a presentation by Dr. Thompson that on presentation. Throughout the presentation, please feel free to submit questions via the chat box located in the bottom right of your screen. After the presentation, we will open a virtual roundtable with questions that we can extend to our panelists and that we will introduce shortly. Before introducing our speakers for tonight, I would now like to welcome those panelists from Latin America. The first is Dr. Silvia Neciasup, and she is the medical oncologist and director of the Division of Medicine of the National Institute of Neoplastic Diseases, INEN, and an assistant medical oncologist at INEN and Oncosalud, AUNA. With a master's degree in molecular oncology and a doctorate in medicine, Dr. Neciasup is professor at the Faculty of Medicine of the University of Applied Sciences and also past president of the Peruvian Society of Histology. Welcome and thank you for joining us. Dr. Antonio Mahfouz Aziz. Dr. Antonio Mahfouz Aziz is an oncology surgeon at Centro Médico ABC in Mexico City. He is a member of the Mexican Academy of Surgery, secretary of the Mexican Board of Certification in Oncology, and ex-medical director of the Institute of Breast Diseases, FUCAM. Thank you for joining us, Dr. Mahfouz. We very much appreciate your time, and we will connect back with our panel following the presentations. Now, on to the debate. It is a privilege, really very much a privilege to introduce our speakers for tonight. I'd like to start with Dr. Matthew James Ellis. He is a physician scientist who completed his training at the University of London and the University of Cambridge. He is currently the director for the Lester and Sue Smith Breast Center at Baylor College of Medicine, where he coordinates an interdisciplinary team of oncologists, pathologists, epidemiologists, basic scientists, and statisticians. He is the Associate Director for Translational Research at the Daniel Duncan Comprehensive Cancer Center. He has championed neoadjuvant endocrine therapy as an alternative to chemotherapy for promoting breast-conserving therapy in postmenopausal women with ER-positive, HER2-negative, stage 2 and 3 disease. Welcome, Dr. Ellis. So
happy to be here.
To see you this evening and to have you with us. I'd also like to introduce Dr. Alastair Thompson, another one of my dear colleagues. Dr. Thompson is an internationally recognized breast surgeon scientist. He was educated and trained in Scotland, despite what his shirt may say, rose to become professor of surgical oncology and lead of a cancer center there, and then moved to Houston in 2014. Initially, he worked at MD Anderson, and now it is our good fortune that he has come to join us here at the Danielle Duncan Cancer Center. Dr. Thompson serves as Section Chief of Breast Surgery in the Division of Surgical Oncology and co-director of the Lester and Sue Smith Breast Center, which is part of the Danielle Duncan Cancer Center. Welcome, Dr. Thompson. Now, does everyone have their popcorn and their beverage ready, because the debate is on? We will start with Dr. Ellis. Dr. Ellis, and do we have Dr. Ellis's slides ready?
Yep, I share my screen, I think. Can everyone see the slides?
Yes.
So pay attention, Dr. Thompson, you might learn something. So it's a great privilege to be part of this interesting experiment in medical education. And thank you, Carla, for your gracious introductions. It's great fun to work with you. So let me see if I can do this. So I'm going to make the case for neoadjuvant endocrine therapy, as Carla described. I actually pulled out some older papers that where I've been was sort of first introduced to this idea of neoadjuvant endocrine therapy. The interest in this was to get an early readout of the relative efficacy of tamoxifen and an aromatase inhibitor over 20 years ago, when aromatase inhibitors were new drugs. And I was approached by Novartis, actually, and a group of academics to conduct, I think is probably the best example of neoadjuvant endocrine therapy trial design, even 20 years later. So this was a one-to-one randomization between letrozole and tamoxifen, and it was a double-blind randomized trial. So patients and the doctors didn't know whether they were getting letrozole or tamoxifen. All patients were ineligible for breast-conserving surgery, which is a very important point. And because obviously these patients went into this trial with the hope that a period of neoadjuvant endocrine therapy could improve their surgical outcome, namely patients who were slated for mastectomy might be able to undergo safe breast conservation. And I also was able to participate in some correlative science in this trial, particularly reconfirming the ER and PR status of these tumors, because of course this is an international trial, and obviously there was probably some variation in the quality of the hormone receptor testing. The bottom line in this trial, although it was modest in size, was there was a statistically significant improvement in breast-conserving surgery. As you can see here, 48% of patients undergoing breast-conserving surgery on the letrozole arm versus 36% on the tamoxifen arm. So that was a difference that was statistically significant and one of the endpoints of the trial. And I think it's because patients didn't know whether they were getting which drug, or doctors didn't know which drug they were getting. This actually led to an approval for letrozole in Europe for neoadjuvant treatment. And I think actually, if you look at the chemotherapy data, interesting to see what Alastair says, But I think that improvement in breast conservation from mastectomy to breast conservation with letrozole is probably the best ever recorded for any therapeutic intervention, chemotherapy or endocrine therapy. So I think that really, for me, established the value for the patient of getting neoadjuvant endocrine therapy. And we'll get into, selecting which patients for which this would be appropriate. I do point out these are all postmenopausal women. The use of this approach in premenopausal women remains understudied. So immediate improvements in surgical outcomes can be anticipated from neoadjuvant endocrine therapy. But the other thing that I was fascinated by, and subsequently we were able to show, is, of course, when you're giving neoadjuvant endocrine therapy, you're actually testing the efficacy of a drug that these patients will obviously be receiving for at least 5 years, and because they're larger tumors and many node positive, even 10 years. And so could we use that response information to track how patients would do over time? And much of this data was sort of generated around the time that multi-gene markers for prognosis were being developed, and the sort of relative value of what I'm about to describe versus multi-gene tests can be debated. But I think it's becoming very obvious that if you measure the tumor proliferation after you've initiated neoadjuvant endocrine therapy, and in this model, this is the proliferation rate in the surgical excised tumor versus looking at the biopsy, what we found was that the proliferation index in the surgically excised tumor, while the patient had received neoadjuvant endocrine therapy right up to the day of surgery, that's how the protocol was written, that was much more prognostic than the baseline Ki67. So it's actually the response. Although the two are related, there's more prognostic value in the Ki67 in the treated specimen. And so we were able to use some multivariate analysis showing that the size of the tumor and the node status are obviously important for prognosis, but also the Ki67 per natural log interval, or 2.7-fold increase. Each fold increase in Ki67 was associated with an increasing hazard ratio for relapse. Obviously, tumors that were found to be ER negative, some of which were clearly ER positive at baseline, but after the neoadjuvant endocrine therapy had become ER negative, which we subsequently showed was due to the presence of an occult ER negative separate tumor, an interesting phenomenon we've suspected for a while, but we're able to prove it here. All these factors are independent variables. So we were able to identify a group of patients, which I think you can see in the Kaplan-Meiers on the left, who had what we call preoperative endocrine prognostic index 0. And this is actually, I think the impact data is better than the P024 data here, because I think Mitch's T67 was better than ours. But you can see here, there's a group of patients in green here out to 72, 84 months that have a very low risk of recurrence. If the Ki67 is fully suppressed in the surgical sample, 2.7% or less, they're node negative and the tumor's T1 or T2. And we reproduced this finding a little later in a trial called Z1031, which compared 3 aromatase inhibitors in a phase 2 design. And you can see that when PEPI was 0, in other words, these tumors with a strong anti-proliferative response and lower pathological stage, very few events compared to the group where there's higher proliferation or higher pathological stage. So reason number 2 to prescribe neoadjuvant endocrine therapy is you might learn something about the behavior of that individual tumor and whether it's likely to behave over time. Now, we have been working as an international consortium to come up with some guidelines as to whether, when, and if you might use neoadjuvant endocrine therapy. In this recent paper in NPJ breast cancer, there's the culmination of that effort. I have to say it was propelled forward by the COVID-19 pandemic because patients were unable to get into surgery often because the hospitals were struggling with COVID patients. And the tendency was to say, hey, put the patient on neoadjuvant endocrine therapy while they're waiting, because it's non-immunosuppressive. It won't put them at risk for COVID-19 any more than the risk they already face. Because we all know if you're on chemotherapy and you get COVID-19, you don't do very well. So here, neoadjuvant endocrine therapy is very appealing. But of course, it has to be given in the most appropriate patient. And so we developed some guidelines here, which I think are generally applicable, not just, during times of COVID, where there's really a group one, which we could go into in great detail, that should go off to the surgeon. That's the group where I think Alastair can roll up his sleeves and do a good operation for them. Those are tumors that are really low ER positive, not ER rich, or a combination of low ER positive and low PR. So those tumors, many of whom actually probably not even luminal tumors, not suitable for neoadjuvant endocrine therapy, whatever the conditions of the hospital are. And over on the right, group 3, these are patients very suitable for neoadjuvant endocrine therapy, patients who have very ER-rich, very PR-rich tumors, and those patients can experience good anti-proliferative responses during neoadjuvant endocrine therapy. And then there's this mixed group in the middle where Mitch and I have worked on this on-treatment Ki67 algorithm where you repeat the biopsy after 1 month. Probably not necessarily in everybody, not in these group 3 patients, but this middle group, this group 2 patients, where repeating the Ki67 and making sure the patient's in response is a good idea. And these tend to be tumors that either have higher Ki67 at diagnosis, about 15%, with lower levels of ER expression. And if you want all the details, you can read the paper. But obviously, this was a consensus reached by a fairly large number of US and actually mostly European physicians, where perhaps neoadjuvant endocrine therapy is used even more than it is in the United States. See if I can get this to move forward. And of course, the other thing, and of course this is my passion, is we still really don't understand ER-positive breast cancer very well. And we've used neoadjuvant trials to relate, for example, genomics to response to aromatase inhibition. And this has led to a number of lines of inquiry I don't have time to go into because this is a clinical debate. But on the left, this is a paper we published in Nature on the genomic structure of aromatase inhibitor-resistant tumors, those that could proliferate despite the profound estrogen deprivation, and those that responded. And it was very clear from this, and you can see the circus plots at the bottom, which is a sort of genomic summary, are very busy for these aromatase inhibitor-resistant tumors and less busy for these aromatase inhibitor-sensitive tumors. And this is because in subsequent work, we were able to link aromatase inhibitor resistance to certain defects in DNA repair, such as mismatch repair and base excision repair. And so these tumors are driven to the endocrine therapy resistance and evolve more rapidly because of these DNA repair defects that are typical of ER-positive disease. And these DNA repair defects are different from the DNA repair defects in triple-negative disease. So this is not homologous recombination defects. This is a different form of DNA repair defect that's causing resistance and molecular progression. The other thing about these ER-positive tumors we're able to show very neatly is that when you have an ER-positive tumor, you don't actually have one cancer. The tumor is multiclonal. And under the influence of the endocrine therapy, and that's really what all these colors mean without going into the details, some clones appear and other clones disappear. And so after even 4 months, you can see there's evolving clones, and the presence of mutations in those clones, which are resistant to treatment, might be the ones that are driving the relapse, and we continue to study these areas. The final trial I wanted to talk to you about is the alternate trial. I'm not going to go into great detail here, but it shows that the fact we could execute this trial really shows that the enthusiasm for neoadjuvant endocrine therapy is increasing. It incorporates many of the principles that I was going through here. But the idea here was, would fulvestrant, an injectable estrogen receptor degrader, be better than anastrozole? but also incorporate this issue of taking an early biopsy to make sure the patients have an endocrine therapy responsive tumor that should continue with the endocrine therapy as opposed to switch to chemotherapy or earlier surgery. And the primary endpoint was the modified FPP score, which I described to you earlier. So can you increase the number of patients in such a good response to neoadjuvant endocrine therapy they can't possibly need chemotherapy and they're done? Other than the surgery, which is obviously occurring in this particular trial after 24 weeks. The result of this trial is that fulvestrant didn't increase the endocrine therapy sensitive disease rate, that's the MPEPI plus the PCR rate, unfortunately. And interestingly, this trial accrued a pretty large number of node-positive patients who I think the node conversion rate with neoadjuvant endocrine therapy is not particularly high, and larger tumors. So it really shows that we have a big population, I think, in the United States of patients presenting with fairly large ER-positive breast cancers and need improvement in drug therapy. And unfortunately here, fulvestrant didn't produce that improvement. But I think this trial will be the ultimate trial to validate the FPP score as a way of determining prognosis, because there was almost 1,400 patients in this trial. So that's plenty of power to validate the FPP score. So my conclusions, firstly, in terms of improvements in surgical outcomes, in a double-blind randomized trial of letrozole versus tamoxifen, the breast-conserving surgery rate was improved. And I know that's a big passion, for Alastair. We all know that breast conservation is preferable when you can achieve it. And the difference was statistically significant and scientifically valid because it was a blinded trial. Unfortunately, fulvestrant is not more effective than anastrozole, and in a phase 2 trial, 3 aromatase inhibitors were equivalent. So I think what all that means is that you should be giving an aromatase inhibitor, it doesn't matter which one, and you shouldn't be giving fulvestrant. The long-term outcomes post-neoadjuvant endocrine therapy is closely related to stage, the degree of Ki67 suppression, and the stability of ER expression. And I described to you the preoperative endocrine prognostic index, which is being prospectively confirmed in alternate. We'll probably have that result in the next couple of years. And I think the guidelines are useful, I described, and the molecular research is fascinating and will drive the future. And finally, I'd say we don't have enough data in premenopausal women to establish a practice recommendation. And with that, I will take questions or hand it over to Alastair, who will give me, point out all my errors, in fact.
Well, thank you for that, Matthew.
Yeah. So Carla wanted to say something, but she was muted. No, she doesn't want to say anything. Okay, off you go.
I will hopefully be able to share my screen with you. There we go. So that was a beautiful exposition of why some women, but not all women with ER-positive breast cancer should get neoadjuvant endocrine therapy. Now, I have a couple of confessions to make. First of all, I work very closely with Matthew, who, as you've heard, is incredibly thoughtful and intelligent, and over the last 20 years has published extensively on the topic of neoadjuvant endocrine therapy. He really knows all the detail, all the molecular biology in the way that almost nobody else could. And on a daily basis, I have the pleasure and the privilege of working with Matthew, who's part of our wonderful multidisciplinary team here at Baylor St. Luke's Medical Center. And you'll see also in imaging, we have Carla there, who's one of the team. But I'm a simple surgeon, and I know that patients like to get rid of their cancer with an operation. And there are even some patients who it may be sufficient to rely on the surgery rather than neoadjuvant therapy, and even very rarely, even adjuvant therapy, that the surgery may do the job for particularly small estrogen receptor positive cancers. So I'm going to work in a different thought process to Matthew's very intelligent, molecular biology driven way of thinking, and think about how we treat women in the real world. If you do surgery first, it's difficult to see of any benefit for neoadjuvant therapy if the original cancer was small and node negative, T1A, T1B, T1C, N0, and not metastasized. And even for larger size breast cancer in a larger breast, even a cancer 2 to 5 or even more than 5 centimeters, it may be possible to excise that cancer and perhaps with a reduction, mastopexy and mammoplasty to get a good breast conservation approach. So size doesn't dictate everything that we need to do. But I think I might be tempted to agree with you, Matthew, that some sort of preoperative therapy is probably the right thing to do for ER-positive, high proliferative, high Ki-67 breast cancers, and certainly for N1 or N2 disease. You're going to learn something about the cancer. You may well convert, as you have clearly demonstrated, women who would be subjected to mastectomy and allow them to have breast conservation. And as you've been demonstrating with that thoughtful publication on what to do during the COVID times, I actually think, Matthew, Dr. Ellis, Professor Ellis, that sometimes you have a point. But let's look at some of the real world evidence. Is there really any benefit to neoadjuvant therapy for those small, less than 2 centimeters, node negative cancers? Many actually may well be cured by surgery alone. Perhaps they'll need some adjuvant endocrine therapy to prevent cancer occurring in that breast again, or even in the other breast. There was a fabulous long-term 10 years follow-up, 200 women patient study from the Royal Marsden Hospital in London, where very thoughtfully, patients with such T1, less than 2 centimeter, ER-positive, node-negative cancers did not undergo axillary surgery at all. And after 10 years, very few of them had had any further bother at all. And that sort of concept of avoiding axillary surgery in these small ER-positive cancers has now been rolled out, as many of you know, in Europe, into the SOUND trial, randomizing patients to no axillary surgery versus conventional sentinel lymph node biopsy. And then I wanted to highlight that there is a trial which has just got out off the ground, just started in the United Kingdom, which is randomizing patients to not having surgery at all when they've got small ER-positive cancers, but asking Carla, the radiologist, and her team to remove the remnants of that small cancer with imaging-guided vacuum-assisted biopsy, avoiding surgery altogether, and certainly not using neoadjuvant therapy. And then we know that if we do have successful surgery for a small ER-positive cancer, if the women are over the age of 65, as the PRIME2 trial throughout the world, with the exception of the Americas, which was conducted to study ER-positive disease in the over 65s, if you've got decent wide margins, there may be very little benefit to radiotherapy. So in these circumstances, why on earth would you want to use neoadjuvant therapy? Neoadjuvant endocrine therapy even, Dr. Ellis? Now, I agree there is some pragmatic evidence that you might want to downsize some cancers, but think about it. With the modern oncoplastic approaches that we have, the bilateral reduction approach for larger size cancers in larger breasts, the ability to take a large piece of tissue out of even a medium-sized breast and then rotate a flap, for example, a LICAP flap, into position. These are all surgical techniques which have become bread and butter, very basic surgery for many of us around the world. And then there are the women for whom, whether you offer them neoadjuvant therapy or not, and regardless of the tumor size, some women actually prefer to have a mastectomy, although it sounds difficult to say that, perhaps a nipple-sparing mastectomy, perhaps a skin-sparing mastectomy, rather than undergo breast conservation with the usual follow-up of radiation therapy. And if a woman up front is saying she wants to have a mastectomy, not that anyone really wants to have a mastectomy, it's unlikely that you're going to change the operation performed by shrinking the cancer down. So, Matthew, I do agree with you, but everyone who's watching this, don't tell him I agree with him on this. Larger node-positive cancers, yep, I can see your point. Larger size cancers in a small breast, yes, of course you may convert a substantial proportion of these women from needing a mastectomy to allowing breast conservation. And you can make what might be quite difficult surgical procedures much more straightforward by shrinking down the cancer. And then for node-positive disease, this is a real problem, as you've just demonstrated from the alternate study, which you have led so valiantly across the United States. Only about 1% or less of patients go from node-positive to node-negative with ER-positive disease in trials like the alternate trial. And given the fact it's so unusual, we're unlikely to reduce the extent of the surgery in the axilla for node-positive disease. So I'm going to finish by thanking everyone for listening. I'd like to celebrate Peruvian Independence Day and ask you to all bear in mind that women are different. And for some women with ER-positive breast cancer, yes, neoadjuvant therapy, but not all women with ER-positive breast cancer should have neoadjuvant endocrine therapy. Thank you for listening. And with that, I'm going to hand back to you, Carla, as chair of this meeting.
Thank you. Thank you. Thank both Matthew and Alastair. I appreciate your presentations for the group. And now we will proceed to the open virtual roundtable with observations and comments from our panelists. I'd like to start with Dr. Nesiasoup. Can you please share what observations you have?
Yes, I want to share the screen, please.
Should be able.
Okay, thank you. Okay, thank you very much for the invitation. Thank you for attending today. Today is Independence Day from Peru. Thank you. I want to show some clinical case. This clinical case is the usual case to see daily. It seems very interesting because it's a woman, postmenopausal woman, 58 years old, no past medical and family history, a low growing right breast node, no other symptoms, and physical examination, Karnofsky 90%, right breast tumor 30 millimeters, mobile without skin infiltration, lymph node 1 centimeter in right axilla. And next. And okay.
Is it advancing for you?
Yeah. Good. What happened? Okay. And the mammogram scan and the breast ultrasound scan only show the tumor node. It's about 25 millimeters. CT scan shows abdominal and pelvic negative. And the biopsy was showed infiltrative ductal carcinoma subtype, NST, grade 2, without perineural and lymphovascular invasion, ER 19%, high level, PR 30%, medium level, R2 negative, and Chi 67, 30%. The diagnosis was invasive ductal carcinoma, right breast luminary. I want to show this case because it's very important to define how can we choose the treatment. For example, we know in this situation it's very complex because we don't have some platforms available, or for example, we don't have a clear surgical tools to define the treatment. We only have a tentative and approved parameters. I want to know what can we do with this patient? What do you think?
So Matthew, do you want to comment first and then we'll have Alastair? I think you may be muted, Matthew.
Can you hear me now?
Yes.
Okay, so thank you so much, Sylvia, for presenting that case. I'll be interested to see what Alastair says. It's a fairly centrally located tumor. It's not too close to the nipple, and there's no nipple retraction, so probably not involving the nipple. But you know, and it does look like a surgery first approach might be possible. But you know, we've all had that experience where you know you start to operate on a patient, and you know that tumor is a lot closer to the nipple you thought. There's a lot of subclinical disease streaming towards the nipple, and the patient can end up with a mastectomy as a result. Also, because it's central location, you know, she might end up with some breast distortion. So I would say it's always better to operate on a smaller cancer than a bigger cancer. And so I think if the patient was willing, a modest period, 4 months or so, to 6 months of neoadjuvant endocrine therapy could be considered. Now, the one thing I would say is the Ki-67 is quite high at 30%. So these are the patients I like to rebiopsy at 1 month, just to be sure that the Ki-67 is being suppressed below 10%. Because some of these tumors are actually resistant, and it certainly wouldn't be the right thing to do to leave those kinds of cases on endocrine therapy for 6 months. So I don't know if you sampled the lymph node in the axilla or not, but I've certainly seen axillary lymph nodes. While we don't obliterate axillary lymph nodes, we certainly see responses in the axillary lymph nodes, as you would expect, and that can be helpful for axillary surgery as well. So I don't. One of the things in my conversations with my friends in Brazil, as you know, my wife's Brazilian, and I spend a lot of time in Campinas and Sao Paulo and Rio de Janeiro, and lots of buddies up there. They don't get their patients into surgery very efficiently. They have restrictions on their surgical case load in the public system. And so again, it's not COVID-19 surgical delay, but you know, certainly if you weren't going to operate on the patients for a couple of months, 3 months, I mean, why not give the neoadjuvant endocrine therapy and monitor the patient carefully? So I think she's a really good case, and I'm interested to know what Alastair thinks.
Yeah, thank you, Matthew. Sylvia, this is a wonderful case to ask us about, and I really hate to say this, but I agree with Matthew, and it's terrible news, but I would love to see how this tumor responds to an initial challenge with endocrine therapy, letrozole, for example, and depending on that response, it might make the surgery less, might allow for breast conservation, even sparing the nipple areolar complex if it's separate from the lumpectomy. I always worry that in the axilla, we will not get quite the same degree of response. And as Matthew was showing you, it's unusual to get a complete pathological response with endocrine therapy. The other issue is whether this patient, if she does not respond very well to endocrine therapy, might be suitable for chemotherapy. On which happy note, I'm maybe going to ask Antonio whether you want to offer a view as well.
Thank you very much. I totally agree with you. Maybe it's a good case to start the treatment with neoadjuvant endocrine or chemotherapy, because the results in general in the studies are quite similar between when we compare neoadjuvant endocrine therapy with neoadjuvant chemotherapy. The results in terms of convert patients to inoperable to operable disease, or to convert patients initially candidates to mastectomy to conservative surgery are the same. So maybe in this case, Dr. Sylvia said, it's not always possible to do a genomic test in the biopsy which maybe get or give us some information if in neoadjuvant endocrine or chemotherapy would be better for these patients. But maybe the surgery, if these patients have a good relation between the tumor and the breast size, a surgery in the first stage could be a good option also.
Yes.
So may I ask you, Sylvia, what did you actually do with this lady?
It was a wonderful discussion, chemotherapy.
Okay.
See, the interesting thing about that decision, and I don't actually disagree too much about the chemotherapy decision with the Ki-67 of 30%. But let's say the Ki-67 was like 20% or 15%. You know, the advantage of neoadjuvant endocrine therapy is increasingly you can identify a group of patients who couldn't possibly benefit from chemotherapy because their prognosis is so good, because they have they have a solid endocrine therapy response. The post-treatment surgical specimen shows that the disease is essentially stopped growing in response to the endocrine drug, the so-called PEPI-0 group, and so why are you giving chemotherapy up front in a patient like that when the patient might escape chemotherapy altogether? So I use chemotherapy very lightly in postmenopausal women with ER-positive disease as a neoadjuvant approach, just because I know that many of them just don't benefit from it. Now, the interesting thing that we're sort of pursuing right now is to sort of further evolve this idea of understanding chemotherapy sensitivity in ER-positive disease in postmenopausal women, because actually in the alternate trial and in the Z1031 trial, even tumors that were resistant to endocrine therapy had an incredibly low PAS-CR rate. So this is a different kind of disease. It's not a younger woman with triple-negative disease or a younger woman even with ER-positive disease. This is a postmenopausal women with ER-rich disease. And even in the original randomized trials looking at chemotherapy, for example, the NSABP trials, and I'm thinking here particularly the B20 trial, in women over 60, no benefit from CMF chemotherapy at all in a randomized trial. So I use chemotherapy very sparingly in postmenopausal women with ER-positive disease, really trying to reserve it for very high Ki-67 tumors or low ER-positive tumors, just because there's not a big role for chemotherapy in these patients, even when their prognosis is poor. Hence, all sorts of de-escalation trials that are going on around the world, like the UK Optima trial. So I don't think chemotherapy is always the wrong answer, but actually it often is. But we need better treatments for sure for the endocrine-resistant tumors that aren't chemotherapy, hence the interest in CDK4/6 inhibitors, for example. And we'll wait to see what all the intriguing data might actually be around the abemaciclib announcement recently. They had a positive adjuvant trial. I think that might be a game changer.
Mm-hmm.
I want to make sure that we have enough time for comments from the audience. So I just want to move to Mexico, to Dr. Mahfouz.
Thank you.
Did you have some specific comments related to their presentations?
Just saying that in some populations with limited access to services and specifically to screening mammography, a significant number of cases are diagnosed by palpation of the breast tumor by their own patients. So the percent of the stages 2 and 3 are very high. And locally advanced breast cancer could be more the reflection of a disease of a slow evolution with no opportunely diagnosed than a disease of a fast development and biologically aggressive. So maybe in our population and also in the rest of the world, two-thirds of the patients, breast cancer patients, are luminal. So in these terms, we must assume that if endocrine neoadjuvant therapy are implemented as the neoadjuvant treatment of choice, maybe the use of chemotherapy could be omitted in the vast majority of our patients.
I think it can. What do you think, Sylvia, about that?
I think she's muted. Sylvia, do you have an opinion about that thought of being able to remove the chemotherapy in the majority of patients?
Yeah, but we always review the case 67, the grade, the age. It's very difficult defined, no? Because when we want to use endocrine therapy, it's very difficult because we need previous excellent biopsy core biopsy. I think the problem maybe is the pathological review. We need to have a very special group of pathology to define, for example, the grade, the invasion or not, the right sites. No, it's very important at this point.
Right. So you struggle, Sylvia, because of that. You need access to high quality pathology, right? Because I think Ki-67 analysis is very, delicate, and you have to have a good pathologist who knows how to read the Ki-67. So I could see that could be a problem. But I think that's something that maybe we could help. We have a good group of pathologists at Baylor. They could come and be trained. We could do all sorts of things probably to help your practice. Because it's very hard to practice good breast oncology without high quality pathology. Actually, I would say it's almost impossible, right? So you make a very good point. Just the quality of biomarker analysis for these kinds of approaches definitely needs to be of the highest order.
Yes, of course.
So there's one other question that we haven't really addressed. And if we go back 30, 40 years ago, in the United Kingdom, we would have quite a lot of patients, particularly older patients, who would be put onto endocrine therapy, and they would not have surgery. They would stay on that endocrine therapy for 1 year, 2 years, 3, 4 years even. And I'm not saying that was a bad idea, but what we used to then see is that 4 years after, usually tamoxifen, the cancer would escape control. And we would have a patient who was maybe less fit because she was older, but with a more challenging cancer, sometimes now with node positive disease. I wondered whether I could ask our friends in Mexico and Peru whether you still see that sort of setting, which I haven't witnessed in the United States recently.
Go on, Sylvia.
I have a question to discuss. Is about genomic profile. Some Japanese groups, they show some results. Maybe the patient who has low risk, the disease-free survival is very longer. But what do you think about this?
So this is this question of primary endocrine therapy, and it might be okay if they have a very low genomic risk score. You can basically just put the patient on the endocrine therapy. The only time I've ever done this are patients who are not fit for surgery at all. They've got multiple comorbidities. They're 96 in a nursing home. They got renal failure, and they're waiting for and they're not doing well, and they're not eligible for a transplant. All this kind of stuff that Alastair and you and me would come across occasionally. But I fundamentally think it's a bad idea. And the reason why I think it's a bad idea is that these ER positive tumors evolve. They're not static. They don't stay low risk. If you watch them long enough, their grade starts to go up and they start to develop progression mutations. And if they're low-grade tumors, it happens over a longer period of time. But if you leave cancer cells in the body, they are prone to doing bad things. So generally speaking, I'm not actually, and the primary, as Alastair knows, the randomized trials of primary endocrine therapy of giving tamoxifen and randomizing to surgery versus not clearly showed you need surgery. patients do worse if they're not operated on. So I don't think there's any place in modern medical practice except under very unusual circumstances of giving primary endocrine therapy. The other thing I have to say for Alastair's first half of his presentation was completely irrelevant because it was a group of patients who didn't need it neoadjuvant therapy, and he was just trying to find something to be, difficult about. But I do think in the parts of the world where screening mammography is less common, like in Brazil and Mexico and Peru, this issue of neoadjuvant therapy is really, really important because most patients are presenting with symptomatic breast masses. They're not presenting with those tiny cancers that Alastair is talking about. That's a privilege of wealthy countries with screening mammography programs and having fantastic radiologists like Carla. But that's not something that the rest of the world necessarily has. So I think that's really what I think about primary endocrine therapy. And I think you have to look carefully at that Japanese study because I'd be very interested in the 10, 15, 20-year follow-up.
Yes.
Because I bet you many of them, I'm sure they did fine for 5 years, but try 10 years or 15 years and you'll start to see the kind of problem that Alastair was referring to.
Yes, thank you.
I do have some questions from the audience, if I can pose that to the panel. The first one's from Narita Esparza. In your practice, how often do you use PEPI scores in these types of cases?
That must be a question for me because the PEPI score is developed for sort of a prognostic indicator. And so every patient I give neoadjuvant endocrine therapy, I'll get the PEPI score. And if they're PEPI 0, I won't offer them adjuvant chemotherapy.
Yeah, I would agree with Matthew that I think it's actually become very useful to have the PEPI score rather than the RCB, the residual cancer burden score, or the pathological complete response, which is relevant for chemotherapy. PEPI is the score you need for the majority of patients who are ER positive if you're trying to give them neoadjuvant endocrine therapy. Is that what we'd all agree on? I wonder.
Actually, it's interesting if you look at the PASCR data to chemotherapy in triple negative disease, and you look at the performance of the PEPI score in ER positive disease in postmenopausal women in defining a low risk group, PEPI score does better because these ER positive tumors are lower malignant potential and they don't get things like brain mets despite having a PASCR, which is something we see very sadly quite often. When a patient presents with an explosive triple negative disease, they get their chemo, they have a great response, their PASCR, they still relapse. But you don't really see that. If they're PEPI 0, these are really markers of very indolent tumors. I can't imagine they would ever be chemotherapy responsive, and the patients have very, very low relapse risk. It's not 0, though, because of the molecular progression problems and subclones that occasionally can grow out, unfortunately. But most patients do extremely well, 95%. That's pretty good. That's like DCIS risk.
Dr. Nesiasup, do you use the PEPI score?
Yes, sometime, but I want to observation in this point because when Dr. Ellis presented the alternate study, the Dr. Ma, they use the FPP Score Modified. No, it's very interesting because maybe the data is more clearly and we have to classify it more clearly to the patient. No, I think the tendency.
Yeah, okay. So you're talking about the modified PEPI score.
Yes.
Well, the modification was necessary because fulvestrant was being used, which reduces the ER level, right? But if you root around in some of our papers, you can see that we have a few cases that were ER positive. They're getting aromatase inhibitor here now. They had an ER positive tumor at the beginning, that an ER negative tumor at the end, and we did extensive genomics, and she actually had 2 different cancers.
Yes.
She actually had an ER positive tumor with 1 genomic signature, and buried underneath it was an ER negative tumor growing right like a thicket tumor, like 2 plants growing together. And of course, by the end of 4 months, the ER positive tumor had gone away, and you only had the ER negative tumor. So you sort of uncovered this ER negative tumor, and then the patient went on to get chemotherapy. So now we know we don't have to use fulvestrant, right? Because it doesn't improve anything. We'll go back to the original FPP score and remeasure ER in the surgical specimen to make sure it's not one of these rare tumors that are with an ER negative tumor hiding, behind an ER positive tumor. Because if you think about it, and I think Alastair, these are called collision tumors, and they're usually diagnosed because there's like a lung cancer metastasized inside a renal cell carcinoma. I don't know if I remember one of these cases from my days as a fellow. They're called collision tumors. There's some breast cancers are collision tumors, two different breast cancers grown into each other. So there's actually, because when there's a tumor in each breast, they're two separate tumors. Or in the opposite quadrants of the same breast, there are two different tumors. But if the two tumors evolved very close together, you'd never be able to make that diagnosis. So we go back, I think, because of all those reasons, I would recommend we use the FPP score. The modification was only because of the use of fulvestrant.
Dr. Mahfouz, do you use the FPP score in Mexico?
I'm sorry, I have no experience with endocrine neoadjuvant therapy. I am surgeon, and most of the neoadjuvant treatments in breast cancer are done by the medical oncologist. So I have not enough experience in neoadjuvant endocrine therapy yet.
Yeah.
Well, that's one advantage for the surgeon, Alastair, because you can give neoadjuvant endocrine therapy. You don't need a medical oncologist.
Yeah.
Yes, for sure.
As you know, and I don't wish to cause offense, Matthew, but one of the beauties of endocrine therapy to a surgeon, and we did this a lot in the United Kingdom, in Scotland, was to start the patients on endocrine therapy and be able to see what happened without needing a medical oncologist. And much as you're a good friend, Matthew, it's very nice to be able to treat these patients and get to know them with the endocrine therapy. The one place that becomes very difficult is in premenopausal women, and I don't know whether maybe just touch on that before we finish.
And there was a question from Jose Caicedo about that issue of neoadjuvant endocrine therapy in premenopausal. And Matthew, I think you touched on it in your presentation, but I think it would be a good way to finish.
Well, we mentioned Japan. Probably the best study of neoadjuvant endocrine therapy was conducted in Japan and was published, I think, in Lancet Oncology, although I'd have to sort of dig it out. I mean, the results are not so dissimilar to postmenopausal women. It's just that premenopausal women are more likely to have higher grade disease, more aggressive tumors, and you have to use ovarian suppression with an aromatase inhibitor. And that led that Japanese group to show that, at least with the LHRH agonist they were using, there was a gradual recovery of the estradiol level over the course of the neoadjuvant therapy, with patients at the end, after 4 or 5 months, getting inadequate ovarian suppression based on the estradiol levels. So if you're going to do it, best on trial, best you monitor the ovarian suppression, best you monitor the Ki-67 on treatment, and you keep an eye on the patient very carefully. But I actually do think that a premenopausal woman with a very ER-rich tumor or a lobular carcinoma with a lower grade or a low Ki-67, it wouldn't be medical malpractice to start it. And I think, we should all gang together and do a proper study of neoadjuvant endocrine therapy in premenopausal women with very strict eligibility criteria that would make even Alastair happy.
Any other comments before we close? I have a few people to thank, but Dr. Mahfouz or Dr. Nasia Soup, any final comments?
No, not only just a little comment about the premenopausal woman, because has Dr. Ellis told something, but it's important to define, because premenopausal women is other type of breast cancer is very different, high risk, aggressive, heterogeneous, probably likelihood with the profile, genomic profile different. No, it's another type of disease. No?
Mm-hmm.
Completely agree.
Yes. Can I make a question for Dr. Ellis? Dr. Ellis,
Yes,
in
please.
case of poor response to neoadjuvant endocrine therapy, could we assume not to use adjuvant endocrine therapy in assuming that there is some resistance to the hormone therapy?
Oh, that's a great question. What do you do with a patient who has resistant disease? Do you change the endocrine drug? Do you switch them to tamoxifen or something? The answer is I don't have a good answer. I know the patient's in trouble, but I was just on the phone with a pharmaceutical company this afternoon, and we think those patients would be excellent candidates for adjuvant CDK4/6 inhibition. So that could be the answer, giving them a drug right now that's only approved in metastatic disease, just like tamoxifen and aromatase inhibitors were once, but bringing that forward for patients who have this endocrine therapy resistant disease to see if we can improve their outcomes. And in distinction, not giving the CDK4/6 inhibitors to patients who are having a very good endocrine therapy response. They probably don't need it. So I think the principle of tailoring the endocrine approach and the systemic treatment approach according to the initial response to endocrine therapy, I think is alive and well, but in a state of evolution, as it always is in medical practice. But I don't have a good answer for these patients because they have primary endocrine therapy resistance. There's some clone in that tumor that's able to grow despite complete estrogen deprivation with an aromatase inhibitor. So there's a disconnect between between the cell cycle and the estrogen receptor. And in some of those, but in a way that all doesn't make them very chemotherapy sensitive either. It's a very unsatisfactory situation, I think, for the medical oncologist. And they'll try things, but I'm worried that a lot of stuff doesn't work for these patients, which is why, they have a high relapse risk, and we need to try new drugs.
Thank you.
Okay, we are past 6 o'clock. First, thank you to all the panelists. Thank you, Dr. Thompson and Dr. Ellis, for leading the lectures today. We always like to close these by recognizing and acknowledging some entities that help to support these programs. Pardon my pronunciation, but Sociedad Peruano de Mastología, Sociedad Peruano de Oncología Médica, Sociedad Peruano de Cancerología, Instituto Nacional de Enfermedades Neoplásicas, and INE in Peru, Hospital San Javier Medical Education Department. We have someone joining us. Instituto Nacional de Cáncer, INCAN in Mexico City, Sociedad Mexicana de Oncología, SMEO, Asociación Mexicana de Mastología, Universidad San Francisco de Quito en Ecuador, Noro Quito en Ecuador, Hospital de los Valles en Quito, Fundación Hondureña contra Cáncer de Mama, FUNHOCAM, Liga Hondureña contra el Cáncer, and Hospital Herrera Grande, Medical Education in Guatemala City. Lastly, we would like to invite you to connect to our 7th virtual roundtable on Thursday, August 6th at 5 p.m. The lecture topic will be COVID and inflammation in the elderly with participation of Dr. Gustavo Rivero. He's assistant professor of hematology oncology at Baylor College of Medicine. To receive updates and reminders, please subscribe to the CHI St. Luke's Health YouTube channel. Thank you very much to everyone this evening. Stay safe, be well. Thanks for joining us. Good night.
Thank you.